I call this meeting to order. Welcome to meeting number 23 of the House of Commons Standing Committee on Health. Today we're going to meet for 1 hour to hear from witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. Before I introduce today's witnesses, a few of the standard reminders for hybrid meetings. This meeting is taking place in a hybrid format pursuant to the House Order of November 25, 2021. For members, please wait until I recognize you by name before speaking, and please mute yourself when you're not speaking. For the witnesses, if you aren't already aware, you have the choice at the bottom of your screen of either floor, English, or French. For those in the room, you can use the earpiece, of course. Please refrain from taking screenshots or photos of your screen. All of the proceedings today will be made available on the House of Commons website. And to our members, in accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests, probably multiple times in advance of the meeting. Let me now welcome the witnesses and tell you how much we appreciate the efforts that you have made to be with us. We very much look forward to hearing from you, and obviously you look very much forward to speaking to us, otherwise you wouldn't keep coming back and having to deal with the exigencies of democracy in Canada in June. So with that, we have with us here today Dr. Wei Hung Yu, Assistant Professor, Department of Pharmacology and Toxicology at the University of Toronto, an independent scientist, Brain Health and Imaging, Centre for Addiction and Mental Health. Dr. Noni MacDonald, Professor of Pediatrics and Infectious Diseases, Dalhousie University and the IWK Health Centre, and from the Canadian Pharmacists Association, Danielle Pace, the Chief Pharmacist Officer. Again, thank you so much for being with us. We're now going to hear opening statements of 5 minutes or less. And Dr. Yu, we're going to start with you. You have the floor. Welcome.
Thank you, Mr. Chair, and the honorable members of this committee for the opportunity to speak with you today. As the chair has mentioned, my name is Ho Yu, and I'm independent scientist in the Brain Health and Imaging Center and Geriatric Mental Health Research Services at the Center for Addiction and Mental Health, or CAMH. Also an assistant professor at the Department of Pharmacology and Toxicology at the University of Toronto, and a member of the Canadian Association for Neuroscience, a professional organization with over 1,000 brain scientists across the country. And I'm here to discuss the impact of brain health in society and the importance of research. It's estimated that 1 in 5 Canadians experiences depression annually, and 2 in 5 young adults experience moderate to serious psychosocial stresses. In this research, we also know that depression and anxiety are risk factors that impact older adults and contribute to dementias like Alzheimer's. This comes from not only clinical research, but basic or fundamental and translational research that untangles the complexity of the brain. In fact, the disabilities of brain disorders represents the largest impediment to productivity. This alone is a major reason to tackle a problem that has only been magnified during the pandemic. And while COVID research has focused on impact on spread and treatments, we need to consider the long-term biological and psychosocial effects from the pandemic to address the brain health needs of Canadians. And researchers have noted that individuals who are experiencing the greatest anxiety are also those who are most vulnerable to COVID, including young children and older adults. During the pandemic, Canada invested extensively in research to ensure the safety and well-being of the people. And this is an example of when resources are committed to scientific research, it can dramatically improve outcomes. In March 2020, right before the start of the pandemic, I actually returned to Canada and came to CAMH after almost 2 decades at Columbia and New York University, and hope that I can represent a reverse brain drain, but this requires the support of stakeholders like yourselves and your colleagues. At CAMH, I've been able to maintain an innovative program in the lab, training early career scientists, and working with my colleagues at CAMH to inform the public on brain health and aging. And from the 2021 census results and globally, we know that one of the fastest growing populations are the elderly. With colleagues across Canada and the world, our mission is to understand the intricacies of the brain, share our knowledge with society, and hopefully abate an oncoming global health crisis of dementia. And funding support is critical for the success of these health programs. And research is part of that integrated and comprehensive process. So when we discuss translational and clinical research, we must also consider the fundamental basic science behind that. Canada has had a successful history of researchers from fundamental science to application. Names like Donald Dr. Donald Strickland, Walter Penfield, Maud Benton, Peter Cullis are only some of the many transformational Canadian scientists. This requires the funding support so that we can maintain and continue to excel in the technology industry and maintain a tradition of excellence in science in Canada. At CAN, we hope that this committee recognizes the importance of this research funding. In recent years, and especially during the pandemic, funding growth has slowed, including those for the tri-councils, which is CIHR and CERC and SHIRC. Couple that with inflation, we are starting to lose the pace in terms of research potential. And Canada slipped to sixth among the G7 nations in terms of R&D spending to GDP. Research investment is not only important for brain health, but it's an economic multiplier, providing not just short-term economic growth, but high-value employment, long-term financial gains, and societal dividends from these discoveries. We also train highly qualified professionals, not just the next generation of scientists, but entrepreneurs, policymakers, and medical professionals, ensuring that medical and technological success for generations to come. COVID hit all of Canada hard. That includes science. Lab faced hyperinflation due to supply chain issues, rising wages, especially for those early career scientists, higher costs for newer technology to compete and innovate. So we ask when the government considers funding priorities, tri-council investment in research be highly valued, including a 25% short-term stimulus and a commitment to sustain annual growth of about 10% to research programs to benefit society economically and medically. I believe Canada research is viable. We have a difficult task ahead of us when it comes to brain health and disorders. And we must also learn from the past, both errors and successes, to ensure that scientific research is robust in this country. We look to this committee and all MPs to sustain research investments through Tri-Council to support generations to come. Thank you.
Thank you, Dr. Yu. Dr. McDonald, do you have the floor for the next 5 minutes? Welcome.
Thank you. I'm pleased to be able to speak to the committee looking at the COVID-19 pandemic and the issues were raised. A number of them are very important. One of the big issues that was raised was equity. There was inequity in the impact of the disease based on age. There was inequity in terms of vaccine access and acceptance. There was inequity in adherence to public health non-pharmaceutical measures. And we certainly saw huge stretching of the healthcare system across the country, some more seriously than others because of differences in the rates of the disease and in the rates of vaccine acceptance across the country. The WHO recognized that one of the major problems that we saw during this pandemic was the infodemic, the misinformation and disinformation, and it has had a huge impact on equity in terms of acceptance of public health measures and in terms of acceptance of vaccines. And this has literally cost Canada millions and millions and millions of dollars. We've done fairly well overall. If you look at Canada and COVID compared to the US, we have about 1/3 the death rate per million. We are also better than the United Kingdom. We're around the rates for Israel, but we're not as good as Norway and a number of other countries. The Royal Society of Canada had a report that I chaired the committee for that looked at COVID vaccine acceptance. And the framework was put forward, and this was presented to you. The executive summary was presented to you. There are 4 domains. Vaccine acceptance is very complex. There are 4 domains that are in the framework, as well as 4 themes. But in the domains, the usual ones we've always talked about is where people are in their place. There's their culture, their social societies, their organizations, but we've added the healthcare system because it really mattered in where the healthcare system was in terms of their practices, in terms of their policies, and in terms of the politics of what was going on during that time. We also recognized immunization. It's the green box in the framework. And the ability to access accurate and reliable knowledge was not the same across Canada, and very clearly showed that we have a deficit in the ability of many of our population to do critical thinking and be able to understand when somebody is trying to con them with misinformation and incorrect recommendations. In the Royal Society of Canada report, there are a number of recommendations for the federal, provincial and territorial governments. Particularly, I want to emphasize numbers 8, numbers 10, number 11, and number 13. Number 8 speaks directly that federal, provincial, and territorial Indigenous governments ensure that all aspects of all of the vaccination process, and I would reiterate, not just COVID vaccine, but routine immunization, because not doing this well costs us money as well. From approval of vaccination programs to adherence to the fundamentals that engender the development of trust are really understood. And there's a table that goes with this in the full report. Number 10, that all jurisdictions put laws in place that support the development and implementation of a national immunization framework that includes equitable access to vaccines across our country. This is for all. This is for vulnerable and minority groups. This is for Blacks, Indigenous, and persons of color. This is for children. This is for the elderly. This is for everyone, equitable access, and that we adhere to the fundamentals that are important for that to happen, and support immunization, for routine immunization across all ages, and also support immunization research. Number 11 is that government departments, including the Departments of Health and Education at the provinces and territorial levels, supported by the federal government, work together to optimize immunization acceptance strategies. And this includes ensuring that we get critical thinking education in our schools, from I would say from grade 1 all the way through to high school and on to post-secondary education, because not doing this means that we are going to continue to be so susceptible to the infodemic, whether it's about health, whether it's about climate change, whether it's about even what provincial government or federal government party is going to come in. There is so much misinformation out there. The other last one is number 13. I wanted to emphasize that federal, provincial, territorial, and Indigenous governments aggressively support upgrading the electronic health information system across the country to ensure that all have patient-centered, fully integrated health information systems. Without this, we made a mess of trying to roll out and know who should get immunizations, who was at highest risk, because we simply didn't have that information. And that's unacceptable in 2022, because we know how to do that. Lastly, I want to say one other thing about our healthcare workers and those in public health. They have suffered significantly what's called moral injury. And this is, they have had to bear witness and fail to be able to act in the way they wanted to act, because there was a failure to support them to do what needed to be done to give the patients the care that they wanted to do, whether they were patients in hospital or whether they were people in the community. And that is just wrong. And to fix moral injury, it's not about giving them a wellness break and saying that they're just burned out. No, it's about our institutions stepping up to support them, to give them what they need to be able to do the jobs that they've been trained to do. Thank you.
Thank you, Dr. McDonald. Next, from the Canadian Pharmacists Association, Danielle Pace. You have the floor.
Thank you, Mr. Chair. Good evening, and thank you for the opportunity to bring a pharmacist's perspective to this important work. My name is Dr. Danielle Pace. I'm the Chief Pharmacist Officer at the Canadian Pharmacists Association. Today, I'm joining you from the traditional and unceded territory of the Three Fires Confederacy of First Nations, the Odawa, Ojibwe, and the Potawatomi. I'd like to focus my remarks on the impact COVID-19 has had on patient access to primary care and how this has changed pharmacy practice in Canada. When the pandemic began, access to regular community health services for patients became very limited. Lockdowns meant that many clinics closed and wait times grew tremendously. Because pharmacies are designated as essential services, we stayed open. It was a scary time for us, and we didn't know how the virus was transmitted or how to keep our staff safe. Adding to this, as everything shut down, patients were coming into pharmacies in droves, trying to renew all their prescriptions at once. Our setup isn't designed to withstand that kind of demand, and so it caused huge pressures on drug supply. With most of our medications manufactured outside of Canada, we didn't know if there would be a long-term impact on supply chain, and so we essentially spent the first few months trying to manage and protect access to medications. At the same time, because we were among the few healthcare services seeing patients in person, we became a primary source for reliable COVID-19 information. It's only recently that we've started to truly understand the toll that those early days have had on our pharmacy workforce. Fast forward a bit, and as the committee will know, pharmacy teams have played a huge role in COVID-19 testing and vaccinations. In fact, we've administered over 17 million COVID-19 vaccine doses, and in some provinces now, they're relying completely on pharmacies to administer these vaccines moving forward. While the pandemic has dominated much of our attention, the opioid crisis continues to rage on. Thanks to a federal exemption provided under the Controlled Drugs and Substances Act, pharmacists have been able to close some of the gaps in care for patients who use opioids and controlled substances. Before the pandemic, if a patient came into the pharmacy on a Friday evening for a dose of methadone and the prescription had expired and their doctor's office was closed, a pharmacist could not dispense that drug. The patient would have been sent to an emergency department, or worse, as we've heard, they would have turned to street drugs and risked an overdose. In the current environment, especially as we're facing shortages of primary providers, access to additional services and care from pharmacists are proving to be extremely valuable to people living in Canada. Unfortunately, our scope and ability to offer equitable care across the country is limited. This is particularly true in our remote and rural communities in our northern territories. Point of care testing, prescribing, and the ability to adapt drug therapy are some areas of pharmacy practice that are vastly inconsistent from one jurisdiction to another. For example, in Quebec, pharmacists were the first in the world to be able to be given the authority to prescribe Paxlovid to treat COVID-19. A few other provinces are now moving in the same direction, but regulatory obstacles have prevented many patients who would benefit from this life-saving therapy from getting it quickly. Limited access to basic care during the pandemic has been the reality for most people living in Canada. Nearly 15% of people went into the pandemic without a regular healthcare provider, and about half have had a hard time getting the care they needed in that first year. The reduced access to care throughout the pandemic and backlogs we're now seeing across the country have also led to delays in diagnosing and treating chronic diseases, which will have long-term impacts on our healthcare system. Pharmacists are already equipped with the skills, knowledge, and expertise to take on further roles in primary care and should continue to be part of the solution. But to do so, we need adequate public funding. Other obstacles include lack of access to patient medical histories, onerous administrative tasks, and barriers to providing virtual pharmacy services. In closing, I'd also like to recognize the invaluable role that pharmacy technicians, pharmacy assistants, and other pharmacy support staff have played as part of our efforts to address the urgent needs of people in Canada. They have put their lives at risk on the front lines, and their critical contributions cannot be underestimated. The pandemic has taken a devastating toll on all of us, but it has also been the catalyst that enabled pharmacists to care for our communities more effectively. We now need supports to maintain these positive changes to healthcare in Canada. Thank you to the committee for the opportunity to share this with you.
Thank you, Dr. Pace. And now we're going to begin with the rounds of questions, starting with Dr. Ellis for 6 minutes, please.
Well, thank you, Mr. Chair, and I certainly want to echo the Chair's comments with all three of your ability to be here and your unbelievable patience. I don't know if I were on the other side what I might have done. I probably would have just left, but that's me. I'm not a very patient person. So thank you very much with great understanding. Dr. McDonald, if I could, you talked a bit about the concept of vaccine hesitancy, and I'm just wondering if you might characterize how what your thoughts are on how Canada did as a country with respect to vaccine hesitancy.
Can I answer that wearing several different hats? My provincial hat, my Public Health Agency of Canada consultant hat, and also my WHO consultant hat. So relatively speaking, Canada, depending on which province you were, did brilliantly well or did not. We have quite a range across our country. Again, I think a big chunk of this was mis and disinformation, as well as we have well learned what politicians say makes a huge difference. And we had not appreciated before the COVID pandemic how much political impact there is on what people decide to do. I helped draft the 2014 WHO report on vaccine hesitancy, and we didn't even talk about politics and the impact of that, nor did we talk about mis and disinformation because it wasn't a big factor. So yes, there are big differences across the country, and there are therefore differences in vaccine acceptance, which led to differences in mortality rate per 100,000.
Yeah,
it
so
mattered where you lived.
right, and certainly, we realize that even on a federal level, there's significant input via political interference and again, stigmatizing, dividing, and name calling, et cetera. It certainly was not in the playbook of vaccine hesitancy and moving that forward, which is exceedingly unfortunate, and I realize that you would certainly agree with that. And I guess one of the things that I always think is important is lessons learned and how we could do that better in the future. Getting politicians not to talk is pretty hard, as you can tell.
So two things that I would raise for that. Number one is my whole emphasis that I tried to put forward, that we really need to be teaching people how to do critical thinking so they can understand when people are speaking to them, are they really using the techniques we know that sell mis and disinformation? And you can be taught this, and we know it. There's evidence to show it works. And when you do it, people are much less prone to mis and disinformation, even if it's coming from a politician. So this is the critical thing that needs to happen, and it needs to happen in our schools. And we need to then move it on beyond that so that, listen, kids influence where parents learn too, and it's a way of getting to parents. We need a national program that's going to address mis and disinformation. And I would say to all of you, each one of you as a politician, you want to get that right, because you really want your information that is, I'm putting this in quotation marks, not disinformation, out there and being used properly.
Well, thanks, Dr. McDonald. And certainly that folds nicely into, the next thing that we'll begin to look at. And certainly it's likely we'd invite you back if you would have us, so to speak. But we're going to start a children's study, of course. And part of that is the negative effects on children with respect to COVID and isolation, language acquisition. Do you have any perhaps brief comments on maybe what you've seen or what you've heard in some studies of what's going on?
Sure. Again, Canada was kind of a middle of the road. We did not shut our schools as completely as a number of other countries did, but we still already have evidence that this has had a negative impact on the development of children, on their reading and writing skills. I think we will not know the full impact of the negative pieces that went with this for probably a decade or two. And the other part of that was it was inequitable. There were families who don't speak English or French, don't have access. You can give them a Chromebook, but they don't know how to use it. And they cannot read the instructions that are being sent along by the teachers. So it was very inequitable how we tried to do virtual teaching. I realize why it was done. There are some of us who think it was overdone and that kids could have gone back to school with masks much earlier. That's a whole other discussion to have. It was a lesson learned. And I very much would welcome coming back to talk more about what I think needs to be done for kids and to try to prepare us for the next time something like this happens, but also prepare us to have kids for the next generation that are going to be much better prepared to not be swung by mis and disinformation. Too many decisions were made on mis and disinformation.
And Dr. McDonald, just have kind of, it's a bit of a hot button topic, but we're talking about vaccines, adverse events, and certainly, again, that's going to be in our lessons learned, I think. How do we, given the complex reporting requirements for vaccine adverse events, how do we then begin to unpackage what we know has happened? And again, I think it has to be part of our lessons learned.
So let me stick to a couple of points, and I need to be full disclosure here. I was a founding member of the Global Advisory Committee on Vaccine Safety for the World Health Organization. So this is something that I've been very involved with for more than 25 years. One of the things we did not do well, we know communications is key. We know that negative information sticks 3 times more than positive information is. So how you present risks and benefits of a vaccine really, really matters. The language matters, how you frame it, how you tell the story. We had too many people who did not understand all the safety components that we had in place in Canada, and that all the vaccines that were approved here in Canada followed all of those steps. There were none that didn't follow those steps. That approval required that. But we did not do good communications. People, again, jumped ahead of what the data was. There were inferences drawn that were just wrong. And I think we should be actually proud of some. We picked up adverse events that were exceedingly rare, okay? When you're talking 1 in 700,000, that's not a common thing to happen. But when you're giving millions and millions and millions of doses, you're going to see some of those events. And so I think that was a surprise for the general public, and maybe for some of the people that were not involved as much in public health and in immunization, where we fully knew this was going to happen, but our communications was not as it should have been. And I don't think we necessarily addressed when these events happened in a way for people to understand the context, understand what it meant and didn't mean. I think there are many people out there who think that the adenoviral vector vaccines are terrible because you can get thrombosis and thrombocytopenia with them. They don't know that you get a higher rate of that with COVID disease by far than you do with the vaccine, as one example.
Thank you, Dr. Ellis. Next, we're going to go to Dr. Hanley, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to all three witnesses. And I also want to give a shout out to Ms. Price for the work of pharmacists during the pandemic and the incredible frontline work. You were really part of the last people still operating and serving Canadians. So thank you for that. I'm also going to concentrate questions on you, Dr. MacDonald. It's really good to see you, and you gave a real tour de force in 5 minutes. I can't believe how much you covered. That is left to unpack. But one area focusing on the getting if we just sort of look forward, where we know that we've lost ground on getting adults in particular, but Canadians to their third dose, and that it is leaving us more vulnerable. Fourth doses in some cases, and we don't know what's coming in terms of recommendations, but knowing what you do know about hesitancy, what do you think we need to do to promote or convince or behavior change, encourage Canadians to get their third and future recommended doses?
You're on mute, Dr. MacDonald.
I wish we could give you some magic silver dust that we could sprinkle across the country. There isn't any magic silver dust. But what we do know, it needs to be multi-strategies. We need to look very specifically at what the issues are in the communities where we're not having the uptake that we need. We need to look at what are their barriers, what are their enablers, what we can do to make that happen. I'm sorry I can't be more precise. Listen, I give lectures that are an hour long that only touch at the tip of the iceberg of the question you just asked. There are a couple of things that we know make a difference. I wish we could get more people singing from the same song sheet, because we know it matters. That's why I pulled up the politicians in our healthcare system. The other thing is, and Dr. Pace has really said it, we didn't necessarily make this easy for people to get immunized. We didn't give them the opportunities to come in at 9 o'clock at night on a Saturday night or a Sunday night. We made it hard, and that undermined it. And then the other thing, and I would say everybody here, you better nod your head. We all want COVID done. We are tired of it. And the general public is tired of it, but that has not made it go away. We're still likely going to see more problems to come. I know we've done well if we look overall compared to the US, for example, but we shouldn't be holding them up as a comparator because they haven't done well. But we've done really quite well at 2 doses. We seriously need to do well at 60 and up with 3 doses. And at 70 and up, we need to do well with 4 doses. And for those that have underlying problems, and again, if we had a fully integrated patient-centered health information system, we would know who all of those are. And so would the pharmacist when they walked in, which we don't have. Then we would be able to really target all of those groups to get exactly what they need. The current time, we can't tell you who's missing. We can tell you who got immunized with COVID, but we can't tell you who's missing because we don't have that kind of an information system. Over. I'm sorry, I could talk for hours on this.
I'm not over yet. Okay, that's great. I'm going to try to squeeze 2 more questions in.
Great.
No, this is fantastic. First is, with your WHO hat, global vaccine. I just read a headline that the South African company has no market for vaccine production. There's no demand. So we know that vaccine hesitancy in some where we're trying to get vaccine to some of the less well-resourced countries is probably an even greater challenge than it is here. Any sort of quick comments on that?
Okay, a couple of quick points to make this, I hope, more understandable. It's complex. Number one is one of the problems in South Africa is about over 80% of people have had COVID. They do not see the value of having the vaccine, even though we know having had COVID, particularly if you had Omicron, you are not protected should we get another variant in that looks like Delta. You need to have had your COVID, you still need to be immunized with at least 1 dose and preferably 2. That's number one. They're having trouble doing that. Number two is their population demographics are very different to our population demographics. Almost 50% of their population is under the age of 20. They did not see the mortality that we saw because they don't have those people. I do a lot of work in sub-Saharan Africa in the other thing that I do called micro research. And I know in working with those countries, it's different. Their diseases are different. Their healthcare system is not a system in many places. And the other problem when the vaccines arrived, all too often they had very short expiry dates. So they just had to give them to anybody who showed up. So they were not able to follow the recommendations to give them to the highest risk people where you were actually going to see the most benefit. And so because of that, the general public did not see the benefit. We saw that benefit in Canada. We saw how it decreased mortality, okay? But they didn't get to do that. Now, can I add the other caveat, which why your question's really important? We do know, and this is not being negative about sub-Saharan Africa, but because they had so much COVID disease going on, mutation was really easy. And they had a lot of people who shed virus for a long period of time because they had untreated, undiagnosed HIV. In fact, some people have said one of the things we really need to do in sub-Saharan Africa is increase HIV diagnosis and HIV treatment. So we will have less shedding of the COVID virus, less opportunity for it to mutate, and that would benefit all of us.
Thank you, Dr. McDonald and Dr. Hanley. Suite, Monsieur Garon.
Mr. Gallon, you have 6 minutes. Thank you very much, Mr. Chair. I'd like to take this opportunity to thank all the witnesses for their very interesting, complete presentations. I really appreciate that. A question for Dr. McDonald. It's perhaps a bit naive, actually. It's a question I'm asking myself quite frequently. I ask this question. Have we gotten to the point of endemicity in Quebec and in Canada after each wave? We hear that that's the case, but if it's not the case, do we have any criteria to know that? Is there anything objective out there?
Sure. I've been asked this many times, and it's not simple. So we would love it to become endemic, to not be mutating further, to move to being, I'm putting this in quotation marks, a meek and mild virus. It hasn't quite gotten to meek and mild. We still have people that are dying from Omicron. We still have people that are being hospitalized with Omicron. I think if I'm being an optimist, one will hope that within a year we will be endemic with a mild to moderate virus that's maybe a bit worse than influenza, i.e. more hospitalizations, more deaths than we see with influenza, but not in the huge wave, but that would mean we don't have a big new variant that comes along, and no one out there can predict that. And if we got a Delta variant and an Omicron variant coming together, it would be wicked. All right, because Delta was so much higher in killing people than Omicron was, and Omicron is so much more infectious. So if you got those two mutations to come together, we'll be in big trouble all over again. Sorry to be a pessimist.
No.
I want to be the optimist.
Dr. McDonald.
Dr. McDonald, if you had been my prof, I would have wanted to become a doctor. Let's say it does one day become endemic. There's this constant debate, about prevention, mask wearing. You hear one thing, you hear the opposite. What does it mean to be endemic in the sense of what does it mean for the future of those measures? In a year and a half, let's say we get there, will we be dealing with this forever?
So I want to be a real infectious disease physician now. Listen, mask wearing is not that hard, folks. In a number of countries in the world, even pre-COVID, people were wearing masks all the time. Masks really decrease respiratory viral infection transmission, influenza, parainfluenza, RSV, and COVID. And so if we could get people to wear their masks in the wintertime, we could decrease hospitalizations for influenza, hospitalizations for RSV, and so on. And that would be with COVID as well. I would also hope that we will be giving both COVID vaccine and influenza vaccine to the designated populations at highest risk every year if it's endemic, so we can decrease the thing. Let me give you one small example that I bet most of you don't know. Do you know that for stroke prevention, because there's a high rate of stroke a week after you get influenza and a high rate of heart attacks a week after you get influenza, just getting the influenza vaccine is almost as impressive in preventing stroke and heart attacks as it is to take your antihypertensive drugs every day. Think about that.
On va certainement y penser.
We certainly will. Thank you. On some days, I'm a bit confused. I wonder whether public health authorities or politicians decide on these measures. Even today in the House, we were working on a motion where House of Commons members, perhaps unlike some of the colleagues here, a number of colleagues in the House were saying they wanted to do away with these measures. Some provinces have done away with them. The federal government hasn't. Do you think with all this confusion, we've gotten to this point because of this politicization of prevention measures?
That's exactly my point. And that's why I'm saying we had never seen politics intrude so much in health policy decision-making as we saw throughout COVID. And you know what? Most politicians don't have the science background to really be able to sift that information and make evidence-based decisions. They make decisions that they think are going to make their constituents happy. And that's often not the right decision.
Dr.
McDonald, I have 1 minute left. And actually, I'm being told I have 1 minute left. Among young people, it seems as though people are interested in looking into vaccines, or some people say, okay, they look and they realize, okay, this protects against this protects against that for 3 months, 6 months, 9 months. Today, if you had to directly speak to young Quebecers and young Canadians, if you had to explain to them why it's important to get vaccinated and what the effectiveness of these vaccines is, what would you say?
So we think these vaccines are actually going to last longer than what we had originally anticipated. We do know that the fourth doses that have been given to those over 70, it was not to boost them above the level they were before, but it was to get them back up to that higher level. But the data so far for younger people is it's working very well, provided you got immunized. Doesn't work so well if you didn't get immunized.
Ce sera tout, merci.
Thank you. Thank you, Mr. Garon.
Mr. Davies, please, for 6 minutes.
Thank you, and thank you to all the witnesses for your patience. Dr. McDonald, the WHO has recently confirmed that there are hundreds of probable cases of severe acute hepatitis in children under investigation worldwide that are not caused, it appears, by the usual hepatitis viruses or any other clear source. Is there any reason to suspect that these unexplained cases of severe acute hepatitis in children are linked to COVID-19?
The data that I've looked at from WHO would suggest, I'm going to say this so carefully, not due to COVID. And we would, because of the huge numbers of COVID disease, even in children, if this was really related to COVID, we should see it. Now, I want to turn that 90 degrees to say, some people and some researchers are suggesting that this may be co-infections, infection with perhaps an adenovirus, enteric adenovirus. And I don't mean the kind that's in the vaccine, but adenovirus that you would get in your GI tract that may then get tipped over because of the circumstances, which might be related to COVID, might be related to other infections that are going on. I think it's going to take another year, probably. I'm hopeful it'll be before we're really going to understand that. But let me give you a parallel. There's a disease called Kawasaki's disease that we know has to be related in some ways to infection. We've been looking for 30 years to find out what it's all about, and we don't know yet.
Okay, thank you. Now, I want to just get your thoughts on infection-acquired immunity. If let's say last month I got infected with Omicron and I recovered, I'd like you to compare the durability and strength of my immunity, as such as I can use that word, compared to if I were vaccinated with an mRNA vaccine in a 2-shot regime that concluded last January.
Okay, so if you had never been immunized and you got Omicron, you are not as well protected as if you'd had your 2 doses of vaccine, because we know Omicron, when we test it, it doesn't, the response to that, your antibody response to that doesn't take out Delta very well if another Delta variant came along. You're narrow in the spectrum. What people that have had Omicron and have not been immunized absolutely need to get at least 1 and possibly 2 doses of vaccine to get them up there to be really protected. And it's very sad and very bad misinformation that people out there who said, oh, I've been infected, I'm protected for life, I don't need to do anything. And that's just wrong.
Can I just probe that out of curiosity a little bit? Now, the mRNA vaccines that Canadians have been immunized with were formulated against the Alpha variant, were they not?
But
so how did those?
But it isn't a yes, no, zero. Okay, so we know that it does well against the Alpha, the Beta, the Delta, and it does modestly well against the Omicron one. Omicron doesn't do well against any of the others. Okay. You're missing two. They come from 2 different phylogenetic trees. The big thing we worry about is that the Delta and the Omicron are going to come back together, and that'll be a mess.
Right. I'd like to also get your thoughts on the impact of vaccination on transmission. Is there a significant difference today on a person's ability to transmit COVID-19, whether they are vaccinated, unvaccinated, or I guess the third category is unvaccinated but COVID exposed and recovered?
Okay, so I need to answer that. I can't be as simple as I would like. I'm sure you would want me to be. The problem is the original Wuhan strain, when you were immunized, actually totally decreased transmission as well. Not completely eliminated transmission, but dropped it substantially. It did not drop transmission as much against Delta, and it doesn't drop transmission very much against Omicron. Omicron is also much more contagious. It grows really well in your upper respiratory tract. You make copious amounts of this virus, may not make you that sick, but you can spread it galore. All right. Okay. So we need some more different vaccines that can help to decrease transmission. But was also why I was answering the question about the masks. Wear your mask.
Got it.
You will decrease.
I don't know if I'll try to squeeze one more question if I can. Dr. McDonald, on March 31, you co-authored an op-ed in the Globe and Mail, and you said this, quote, "A lack of vaccine acceptance is a symptom of ongoing mistrust that is our collective colonial lineage. Acknowledging and supporting Indigenous peoples' right to self-determination, the right to choose, is a critical step in addressing COVID-19 vaccine mistrust. Indigenous peoples have the right to credible and culturally relevant information in order to make an informed choice. They have the right to question. They have the right to say no. Given the direct connection between vaccination and colonialism that you were making, are you concerned that vaccine mandates could reinforce COVID-19 vaccine mistrust among Indigenous people?
I would hope those mandates would be done with and in collaboration with Indigenous physicians and healthcare providers so that they can literally, and I'm putting this in quotation marks, translate why this is being done in and how it fits with Indigenous views on health and well-being.
But have they done that? Is my question.
They have tried, and in a number of places have been quite successful, and in others we just simply don't have enough Indigenous healthcare providers to be able to do what needs to be done.
Thank you, Dr. McDonald. Thank you,
Dr.
Mr.
McDonald.
Davies. Next, we're going to go to Mr. Lake, please, for 5 minutes.
This is so fascinating, and I don't know where to go. I almost feel like I need to ask the other two people a question, but I'm just going to go down this road a little bit. So I'm not a medical expert, like most members of Parliament aren't medical experts. I come from a business background, so I like to think that I have some expertise in negotiation and persuasion, maybe. And that, I think, is relevant here. I did write an op-ed on vaccine hesitancy in 2019 because I have a son with autism and would have described myself as vaccine hesitant back 20-some years ago because of the Wakefield situation coming out of the UK. And so my op-ed in 2019, pre-COVID, was to convince people that vaccines don't cause autism and address vaccine hesitancy from that standpoint. And I had the chance to talk to many experts about this. And the approach that I took at the time was to, as a parent of someone with autism, try to understand and show some empathy and to ask the types of questions that they might ask of some of the experts I had the chance to quote in my op-ed. I am very concerned about the way that we've communicated over the last 2 years with people who are vaccine hesitant. And I know when you're talking about politicians, I sense that you're pointing at some politicians maybe within my own political persuasion or sphere. But we have one prime minister in this country, and that prime minister referred to people who don't get vaccinated as misogynists and racists and those people and a lot of other things. And I think people who have chosen not to get vaccinated choose not to get vaccinated largely because they think the vaccine is going to hurt them. And I think our approach should be to persuade them based on evidence that they should get vaccinated because they're safer when they get vaccinated and people around them are safer. What would you maybe do differently if you could revisit the last 2 years in terms of communications?
So first of all, we needed much better communications out there. And, communication experts know what they're doing, but they have to know the science behind it to know what it is they need to be doing. So that's the general communications, the media communications. I think your comments are really important. You have to listen to what the concerns are. Then you need to find out what they know and what they don't know at the individual level. Then you need to see if you can offer them some information that might be helpful after you're trying to build this kind of trust. And then you need to find out if they understand and have more questions for what you've told them. And when you do this, many of these people can move from being vaccine hesitant or resistant to being, yes, I will accept it when it's done one-on-one like that. That it's called mini motivational interviewing. We've done national studies with this in Canada for routine immunization. It can be very successful. It is not expensive to do, but we did not do it well during COVID. And we needed many more healthcare providers who were trained in being able to do this, whether it was pharmacists, whether it was frontline nurses, whether it was family physicians. We just needed many more people out there who could listen well and find out what the obstacles are. For some of our Indigenous populations, it was past history. For some people, it was what their local MP said. For some people, it was what their local MLA said. For some people, it was what their religious leader said. There were all kinds of people out there crowing that they knew what to do and told people what they thought they needed to do, not based on what the evidence was.
If I may be so bold.
Absolutely, absolutely.
I gotta say, I see such a strong role for pharmacists to address both vaccine hesitancy and misinformation.
Yes.
And, you know, as someone that gave COVID-19 vaccines and had this beautiful protected time with patients where I can make sure that that experience was a positive one so that they felt confident about that informed choice that they were making, and that they told their friends and they shared their experience and highlighted the pharmacist as a reliable source of valuable, important health information. That's part of it. And so I think that in saying that, we also need pharmacy services to be funded so that we can continue to provide care. You know, traditionally the model has been we've seen pharmacists in more a dispensary role, but those days are gone. We really do need to access and utilize our medication experts who are conveniently located within 5 kilometers of most Canadians. So I mean, I obviously am biased, but I really do feel that pharmacists can be part of this solution, especially as we move forward and we talk about promotions of vaccines and addressing vaccine hesitancy, addressing misinformation, not just in the vaccine space, but drug misinformation as well. I mean, there's so much opportunity, and I appreciate the conversation and the dialogue, and I almost feel like I was sitting in on a CE with Dr. McDonald. So thank you very much for all the wisdom that you shared in your responses.
I don't have time for another question, but I just want to make a comment on the pharmacist side that I'm fortunate to live in a province where pharmacists have been given a more substantial role in Alberta, and I'll tell you, it is of huge benefit to the people in Alberta. I'll just throw that out. Thank you.
Thank you,
and
Mr.
bad language about people who don't accept vaccines is totally unhelpful.
Thank you, Dr. McDonald. Next, Dr. Pawlowski for 5 minutes, please.
I think we're all aware of the impacts that social distancing measures and lockdowns have had on people, the adverse effects. Certainly you, Dr. McDonald, as a pediatrician, and have spoken about the adverse effects on education. I think Dr. Hughes talked about the effects on the elderly, the effects on depression, the higher suicide rate. This has created its own large umbrella of other health problems. I wanted to ask you, Dr. McDonald, as an infectious disease expert. Now, I know you're a pediatrician, so maybe you don't have as much experience with it, but the value of treatment options and specifically Paxlovid, we want to, as much as possible, I think, try to avoid further shutdowns, having to use these distancing measures. And it would seem to me that we're not doing as much as we could in terms of getting people who are high risk treated with Paxlovid to decrease the rates of hospitalization, ICU admissions. Do you agree with that, or do you want to comment on that? I think you're muted, Dr. McDonald.
Yes, that would be helpful, but let me reframe it for you. Which is better, to prevent the fire or get to the fire early? It's always better to prevent the fire if we can. And Paxlovid is only trying to put the fire out when it's already burning. And yes, sometimes it works. Yes, it can decrease it, but it's not 100% effective. All right. It doesn't say as soon as I pop that pill, I'm not going to get sick and I'm not going to have bad disease. The data are not there for I mean, it helps, but it's better if you didn't get it in the first place.
Yeah, perhaps it's better. I certainly agree, and the dogma in public health is certainly prevention is far better than treatment. But perhaps, though, we've gotten as far as we're going to get in terms of vaccinating people. I'm not sure how many more people we can convince, and if that's the case, how much is that an option, and what should we be doing more in terms of making it available so that people who are high risk and doctors are aware of the benefits of giving it early?
I think the problem there comes back to what Dr. Plest was saying. It would be really better if it was widely available in pharmacies. It probably never will be in terms of the needs for where it is, that One simply needed to have a positive test that was confirmed, because we don't want this being taken by people who don't have COVID, but they've got a runny nose and a cough. And then it needs to be there as quickly as possible. Yes, it works up to 5 days, but it's better if it's before 5 days when you're giving it. So I think there's a lot of things in system rollout that make it complicated and difficult. And I'm not sure we'll ever get that all smoothed out. We can do better, but it will never be lickety split out the door.
And I guess
Can I offer some?
I was going to ask Dr. Pace, because pharmacies in Quebec are prescribing that. How is that worked? And is there anything in the Quebec regulatory system which has allowed them to do it, but's prevented other provinces from doing something similar?
Yes, thank you so much for the question. As of April, 4,500 patients in Quebec have received Paxlovid, and about 70% of those prescriptions were written by pharmacists since April 1st. So, a key enabler, I would say, has been virtual prescribing, so that symptomatic patients don't show up at the pharmacy door. The Quebec government has recognized the complexity and the time needed to ensure safe prescribing, and providing pharmacies with the appropriate funding, but also resources to do this, has been instrumental in increasing that access. Patients are able to have deliveries, home deliveries for the rapid antigen test. They're able to confirm their diagnosis. They're able to consult with their pharmacist over the telephone. It's just a very well thought out model, and it's working. And we're starting to see it. Alberta, Newfoundland, Saskatchewan, we're starting to see that trend. And as these provinces work within the regulations to enable and remove these barriers, I think we're going to really be able to improve access, and the impact that will have on COVID and getting rid of it, as in getting us back to normal, I think will be significant.
Thank you, Dr. Pace. Thank you, Dr. Pawlowski. Suite, Monsieur Garon, pour 2 minutes et demie.
2.5 minutes, Mr. Garon. Thank you, Mr. Chair. A question for Dr. Yu, who referred to the importance of research. You referred to funding it, doing it, and having high-quality research and researchers. I'm very touched by that. Yesterday, in the tabling of a motion by the Bloc Québécois in the House, the Bloc suggested that rather than have really challenging criteria on research chair attributions, that there should be an increase in funding grants for the Tri-Council. And if there were more of these grants, there would be more diversity in that pool of researchers that we have, people who could become university profs. Would you agree that there should be an enhancement of these types of fellowships or grants? Do you think it's really important also in terms of diversity?
So thank you very much for the question, Professor McGraw. I do agree that Tri-Council funding should be increased, and that shouldn't necessarily be at the expense of other programs like the CRC or the CFI. They really are all important for maintaining and innovating for research in terms of equity, in terms of the diversity of research, as well as the diversity of individuals who can. I think one of the most difficult factors right now, especially for Tri-Council funding, is what are we going to do with the next generation of scientists? I've been around quite a while, and I'm happy and delighted when I see early career researchers getting their funding. For example, my postdoc just got funding from an agency a couple of months ago. These are celebratory events, and they're not happening enough these days. And let me just give you one stat, since 2000, because of funding leveling of research, we really haven't had an increase for early career researchers since 2003. That's going to affect the future of research, and that's going to affect the ability to attract talent. So funding like Tri-Council is very essential for making sure that the landscape has that parity, has that innovation for the future. Thank you very much for the question.
Merci, Monsieur Garon.
Thank you, Mr. Garon.
Next, Mr. Davies, please, for 2.5 minutes.
Thank you, Mr. Chair. I'd like to go back to the issue, if I can, about immune acquired infection-acquired immunity. I have seen other data, and other immunologists have stated that using a vaccine that was developed against the alpha variant, boosting it to deal with a virus in circulation that has mutated significantly, particularly on the spike protein, by logic should reduce its efficacy. But I'm not sure if, like, what would your position on that be, Dr. McDonald? So in other words, if we get a third booster or a fourth booster, are we not just boosting the production of antibodies to deal with a virus that is not particularly in circulation as it once was?
Yes, but let me explain. People are looking now, and the companies have been looking very hard about putting together a vaccine that would have two pieces in it. One that would have the spike protein that was for the original Wuhan, which is in the one that we've been using on millions and millions of people. And the other one would have the Omicron variant of that spike protein, looking at what would happen if it was given together. And I think that's really the question you're asking. And
well,
yes,
if I
that
may
would
interrupt,
probably...
It actually isn't, because, but you've nailed the nub of the question. We are not using, that would make sense to me if we were, but we're actually using the vaccine that is purely developed for the alpha spike protein.
Right.
And I'm just wondering how effective can that be against a spike protein that has gone through such significant mutations?
Well, it has gone through significant mutations, but there's a lot of places that it hasn't changed, okay? And when you respond, it's to all the different pieces that are on the spike protein, okay? And that's why it still works against serious disease, against Omicron. If you've been immunized, you're not going to die at the same rate, and you're not going to have hospitalization at the same rate.
The data seems to back that up. The other question I want to just challenge you on a little bit is, I've also the evidence that I've received from other immunologists is that if you are infected by Omicron, I have had certain immunologists tell me that does provide protection against previous versions of the virus. Well, that it would actually contain some of the same, I don't know the proper term.
It has some of it, but it is not good against Delta, for example. It's wimpy against Delta, okay? And it's not, there are two phylogenetic trees that have come off, the Omicron branch, blah, 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 and the one that had alpha, beta, delta off of it. They're quite far apart in terms of what they're like. Omicron is not as good, I'm putting this in quotation marks, it's not as good an antigen antibody generator as the ones that were off Wuhan and the beginning one. They do better at stimulating neutralizing antibody against the spike protein. The problem is with Omicron, it's variant a little bit so that the neutralizing antibodies aren't quite as good a fit as they would be for the original one. I'm trying to think if I can give you an analogy. Maybe you have both moccasins and you have winter boots and you have dress shoes, and the dress shoes fit tighter than your winter boots were if you don't put your shoes in those boots. It's kind of the same thing. They're sloppy, the fit from the Wuhan to fit to the Omicron. And because of that, it doesn't protect you as well.
I see.
The reason people don't want to just do an Omicron variant vaccine is we know that's not the last variant we're going to have. And we want to try to be protective against that whole family. And they're now working on trying to get a COVID family vaccine that would protect you against the whole family, not just the ones that we've been detecting.
Well,
Thank you, Dr. McDonald.
Here is I've got to go buy myself some more shoes.
and the big takeaway is we need more research money, and that means we need to give more money to CIHR and the other tri-councils.
Okay, that's a good note on which to finish. This has been a fascinating discussion. It's thanks to everyone. It would be great if we could keep it going for 2 hours, but thanks again for the efforts that you made to be here. Thank you so much for your presentations and for your answers. It has been extremely informative for all of us. This has been an exceptional session. is it the will of the committee to adjourn? It is. Okay, we're adjourned. Thanks, everyone.
Thank you.
Thank you, everyone. Good night.